I will just get right started. So we know that AI systems are being introduced in healthcare and medicine. And very often we have, particularly in public perception, a very inflated high view of what these systems can or can't achieve. This is but one example of an AI system used in the UK to triage COVID-19 patients. So you can take a look. It was published by the MIT Tech Review in April 2020, so super early at the beginning of the COVID pandemic. And the idea was to basically have patients chest X-ray scanned and triage them and diagnose COVID-induced pneumonia quicker than by using PCR tests, which was quite time-consuming at the beginning of the pandemic. And if you take a look at the time, it's quite optimistic, right? So it says doctors are using AI to triage COVID patients. The tools may be here to stay. So it seems to be quite promising. This was published by the same newspaper a year later, July 2021. And if you take a look at the title, it's less optimistic, let's say. So hundreds of AI tools have been built to catch COVID, none of them help. So you see sometimes you have very optimistic views once AI starts to become part of, enter the medical field. But then we also need to be aware that these systems can fail. So I will, just from the start, I will be quite critical today during this presentation because I will be focusing on a very specific form of injustice. But I just want to say up front that I'm not against using these systems in healthcare. As a matter of fact, I think that there are a lot of promising uses, but we need to be aware of the possible consequences, and not only from a system perspective, things that we can fix at a technical level, but also we need to be wary of the political power dynamics that underlie the introduction of these systems in medical care. So this is basic. So my presentation today is at the intersection between epistemology and ethics of AI. And epistemology is a term that covers basically everything that is knowledge related. So terms like understanding, information sharing, knowledge are all epistemic terms. And when it comes to AI systems, we have a very big epistemic component to it, if you want. So this is a very sketchy representation of a deep neural network. So you have a set of input layers, then you have an output layer, an output that can be, for example, a treatment recommendation or a diagnosis that an AI provides to a doctor. But then you don't really know what happens in between. This is very often discussed as the black box problem or the problem of epistemic opacity. So you have, as a human knower, some sort of inaccessibility to what happens in the black box. So you have a treatment recommendation as a physician, and you very often do not know how the system connected input to output. That is, you can very hardly reconstruct the decision-making logic, if you want, of the system. So, and so this is an epistemic problem because it pertains to the knowledge that we have or do not have often of how certain outputs are created by AI systems. And so this epistemic problem is connected to a whole lot of ethical issues. So considering a treatment recommendation that is created by an AI system, well, if we do not know as physicians how the system created the output, are we justified in following through with it? So are we justified to prescribe to patient X treatment Y, for example? Can we responsibly diverge from the treatment recommendation if these systems are supposed to be the most precise tools that we have available now in medicine, for example? So this has led a whole lot of scholar debate on central topics in ethics, so moral responsibility. Can we responsibly diverge from the diagnosis or from the treatment recommendations, or can we responsibly follow it? Trust, so can we say that we are justified in relying upon these systems? Are they even worthy of our trust? Well, we usually actually ascribe to interpersonal relations. Yeah, are we epistemically and morally justified for acting upon an outcome? So these are all issues that happen, so these discussions happen at the intersection between ethics and epistemology of AI and have received quite a lot of attention, very much justifiably, in the academic debate. But there is a further topic that is also pretty much at the heart of this intersection, but that has comparatively at least received less attention. So the idea of today is to just try and see whether there is some merit to taking a look at this concept that has been so far analyzed in the context of social epistemology in mostly non-AI related contexts, to apply it to understand a specific form of injustice that happens once AI systems enter the medical field, enter patient-clinician interactions. And so this is a quote that I think quite nicely summarizes the idea, the most general idea behind epistemic injustice. It is taken from the Radcliffe Handbook of Epistemic Injustice, and just going to read it out loud. It says, in the era of information and communication, issues of misinformation and miscommunication are more pressing than ever. Who has voice and who doesn't? Are voices interacting with equal agency and power? In whose terms are they communicating? Who is being understood and who isn't, and at what cost? Who is being believed and who is even being acknowledged and engaged with? So I marked in red some key terms, if you want. So you see understandings, understood, believe, which are all epistemic terms that pertain to knowledge, right? And but you also have agency, power. So you have also very big political dimension to this concept. So this is the plan for the remainder of my presentation. I will first start with a case of an AI system that is currently used in the US to predict patients' risk of opioid misuse. And in the second part of the presentation, I will explain the concept of epistemic injustice in its standard formulation a bit more. And I will try to argue that these cases, the snark-scare algorithms, bring about a form of epistemic injustice. And then I will try to very sketchy, very briefly point towards some ways forward before concluding. So, there is a very big problem in the US with opioid addiction and misuse. So these AI-based systems are currently introduced in medical care to predict patients' likelihood of developing a drug addiction or opioid misuse. And the algorithmic platform that is currently used is called NarcScare, and it is a proprietary algorithm. So basically, we have no explanation to end users as to how a certain risk score has been attributed to a certain patient. So above and beyond the technical black box problem that I referred to at the beginning of the presentation, we have another layer of opacity, if you want, that comes from the fact that the company owning the system does not share much information about the proxies used, about how this risk scores, what the kind of data that is used to inform the risk scores, etc. So there is a more general form of opacity, if you want. And we don't know much about the proxies, as I was saying, but we do know something about them, and what we know is quite concerning. So a legal scholar looked very closely into how these risk scores are generated by the system, and some proxies are not necessarily connected to a person developing a drug abuse. So for example, just to give you a quick example, whether a patient has had a history of sexual abuse, for example, and this information enters their medical record once they seek, for example, psychological support, is something that automatically informs the risk score. And if you think about it, most of the people, well, the majority of people who experience this kind of events are women. So de facto, eventually, women end up having a higher risk score compared to the male population. We can talk more maybe about this during the discussion later, but there are also other proxies that do not necessarily pertain to a risk of developing drug abuse. So if the idea is to target patients who are at risk, it's also to target physicians who could be labeled as overprescribers. And this can have very serious consequences for them, even losing their practice and license. So if a physician decides to prescribe opioids to a patient who has been assigned a very high risk score, they do this at their own peril, which creates some sort of dependence to the systems to the extent that one is probably very hesitant to diverge from a high risk score. And I include also this quote because it says NARC's care predictive platforms deserve serious scrutiny because they are the only law enforcement developed digital surveillance systems that healthcare providers have ever utilized to diagnose and treat patients. So the problem, and I want to say this upfront already, it's not only at the technical level of the particular system, so flawed proxies, etc., but it seems to be at a much broader societal, institutional setup that allows for these systems to play this powerful role in medical interactions. And Wired reported from of this patient was dismissed basically from the hospital due to a high risk score. She was administered opioids due to endometriosis, which is a very painful condition. And there are a whole lot of problems connected to this case. So the person didn't know, first of all, that an AI was involved in the decision-making process in the first place. It is unclear what kind of data, again, informs the risk score. So from an ethical perspective, there is so much to unpack. But what I'm interested in doing today is asking the question of what is the injustice that I think our moral intuitions tell us something is wrong, there is an injustice going on, and the idea is, can we understand the injustice that this person is experiencing as a form of epistemic injustice, on top of the fact that, for example, she didn't get the medication she needed. So I'm not here to talk a bit more about epistemic injustice in AI, but first about epistemic injustice in general as a concept. So the term has been introduced by Miranda Fricker with her book, Epistemic Injustice, Power and the Ethics of Knowing, which has been published in 2007. And according to Fricker, in its most general terms, epistemic injustices are wronged down to someone specifically in the capacity as a knower. And in the standard framework, there are two main forms of epistemic injustice, testimonial and hermeneutical injustice. Drawing on this standard framework, a whole lot of work has been done to develop and broaden the concept of epistemic injustice and to apply it to the medical field. So there is quite some literature in social epistemology on this concept. But I will just very briefly explain the two standard forms of it. So the first one, testimonial injustice. So according to Fricker, someone is a victim of testimonial injustice if she receives, as a consequence of prejudices, less credibility than she deserves. And to give you a very standard example, if you think of a medical encounter where you have a female patient and a male physician, and the patient reports her symptom or expresses pain, and the male physician, let's say, does not give any credibility to her testimony because of certain unjustified prejudices about the fact that women are more apt to complain than men, or overdramatic, etc., then she is the victim of an epistemic injustice because her credibility is unduly reduced, if you want. And of course, this can have very concrete and practical consequences. So if we do not take patients' self-reported symptoms seriously, for example, this can lead to a misdiagnosis. But from the epistemic perspective, the patient is not treated as an epistemic agent that can, in fact, provide relevant knowledge that is relevant for medical decision-making. So it is a problem that is connected to practical consequences, but it's not to be reduced to practical consequences. So this is testimonial injustice. And in the context of AI and the rest of the presentation, I will mostly focus on this form of epistemic injustice, but there is a lot to say also about hermeneutical injustice. I will just briefly explain what it is, but I will not go into the details later. Hermeneutical injustice occurs when a gap in collective interpreted resources puts someone at an unfair disadvantage when it comes to making sense of their social experience. So if testimonial injustice happens at the interpersonal level between a hearer, a physician, and a speaker, patient, hermeneutical injustice is much more structural. Just to give you an example, postpartum depression. So before the concept was available in our shared pool of collectively understood, medically understood concepts, women experiencing what we now know is postpartum depression were made morally blameworthy for example, neglecting their child after birth. and or because they weren't able to live up to the standards of motherhood imposed by society. Now we know it is a medical condition that requires due medical attention, and the fact that it took so long to recognize it as a medical condition is also due to, well, to structural injustices and inequalities, and the fact that the male body has been for a long time the standard of biomedical inquiry. So in this case, we do not have an active agent that perpetrates the injustice, but it's more at the level of the concept that we have available to understand our own lived experience in the first place, and as a consequence also to make it intelligible to other people. Now we turn to what AI can do basically, and how AI can affect the patient-physician relationship. So, thinking in terms of epistemic injustice, one needs to start to think in terms of power imbalances. So once an AI system enters a simplified clinical encounter between a patient and a physician, we have a third very powerful epistemic knowledge-generating entity that is supposed to say something very meaningful and most probably accurate about the health status of a person. So we do not only have the physician as a knowledge entity, but we also have the AI system. So we need to take a look at what this does at the epistemic position of the patient. There is also a risk that has been also empirically studied quite a lot by now of clinicians' over-reliance on this system, so-called automation bias. So the fact that very often we tend to over-rely on the performance of the systems. And the combination of these factors and more factors, of course, can lead to illegitimately disregard patients' knowledge and devalue the credibility of their testimony. Now, I'm relating this conversation explicitly to the case that I mentioned in the beginning of the presentation. So, considering the opioid case I mentioned at the beginning, I think that if the authority of the AI system risk scores overrides the legitimacy of the patient's testimony, we're heading towards testimonial injustice. Plus, if there is some sort of impossibility, either practical or otherwise, for the patient to contradict what is felt like an inaccurate risk score, and if we have a more broad underestimation of pain and an illegitimate dismissal of the self-reported symptoms of patients, we are dealing with a testimonial injustice. Now, how does this happen in the particular case? So, So I think there are two scenarios that make, so I think this happens because narc-scale risk scores are often treated as markers of trustworthiness. So often when we have testimonial exchanges, so when we accept people's testimony, we want to make sure that what they're telling us is either true or at least truth conducive. So we kind of tend to look for other markers that in some way support the legitimacy of a person's testimony. And in medical encounters, there are probably two scenarios that make markers of trustworthiness either important or not so important. So in the first case, we can have situations where we have a very obvious and objectively recognizable cause that connects a patient's self-report, testimony, symptoms to the cause. So if we have an X-ray and the X-ray shows a broken bone, we don't really need something that supports a patient's testimony that the arm hurts. It's very clear. So no need for, to look for further markers of trustworthiness. But in the second case, when patient self-reported symptoms is the main or even the only way for physicians to assess their medical condition, as it is often the case in chronic pain patients or in psychosomatic diseases or in pain management more generally, then probably the idea behind this risk scores is to add something to the testimony of the patient, to try, and I think this is the idea at least behind the use of these risk scores in the first place, to support something that is allegedly, in very big air quotes, objective and neutral, that supports the value of the patient's testimony. So, and this can be very risky, because it can lead to the fact that the testimony of the patient and their self-lived experience of disease is basically not taken seriously anymore, and that these systems end up, well, replacing what the kind of information that we know we need to know actually from the patient self-report. So one can ask, okay, but are NARTH risk scores really markers of trustworthiness, or are they used this way? And I think there is some quite some empirical research that shows that, yeah, it is effectively done. So this is just a quote taken from a paper in which clinicians using this PDMP profiles is basically the NARTH risk score. Using these systems, they say response algorithm scores with new patients participants, that is clinicians using these risk scores, reported declining to prescribe except in the case of acute verifiable conditions. Now, if you take a look at these two scenarios, scenario one is the case where you have acute verifiable conditions. So basically what the quote says, only in cases that fall under scenario one would a physician decide to prescribe opioids in spite of a high-risk score, but not in all other cases, which are, one could say, the relevant ones, where we need to take into consideration the patient's testimony. So it seems like these systems are playing a very big role when it comes to, well, to decision-making in pain management. And this can lead more to, well, disregarding patient's knowledge, basically. So this are also two quotes of physicians using the system. So one says it's a cat and mouse thing, so I keep it, the score, secret as much as possible, which is an attitude of complete avoidance that doesn't leave the patient with the possibility of, you know, reacting to what is possibly felt as an inaccurate risk score, for example. And the second one says, I will leave the room and get something and pull it. So the report, the risk score, I may confront them, the patients, if it seems like they're lying and say, well, here's what I got here. It seems like you have to be very honest with me, so I'm not going to prescribe you to give you your prescriptions. So, which is very confrontational, but still puts the patient in the position of not being able to give credible information about their own health status. What I want to clarify maybe already is that epistemic justice would not entail that we always have to take patients' self-reported symptoms at face value. This is not the idea. The idea is that we have to take the testimony seriously and that we do not dismiss it based on certain prejudices or biases. And one of this could be also the fact that the AI system knows better about the patient's status than the patient himself. But if there are medically valid reasons as to why a patient is lying about their opioid consumption, for example, of course, there should be a conversation, and it's not like clinicians should always follow through with what the patient is telling them. So this is just a very important clarification, because epistemic justice doesn't mean just always following through. It's a very specific form of illegitimate dismissal of a person's testimony. And so I've been talking about this problem from the perspective of the patients, but of course, this also impacts physicians in their professional roles quite a lot. So there is limited understanding for both patients and physicians. So we have a technical problem in terms of the black box, but also the unwillingness of the company that owns these algorithms to disclose information. So a more general lack of explanatory resources that, yeah, can lead to some forms of communication impairments also between patients and clinicians. And according to the standard framework of epistemic injustice, so according to Fricker, how do we remedy epistemic injustices? Through the virtue of epistemic justice or testimonial justice. So we are aware that in society there are certain biases, like identity prejudice, for example. So we try to develop a virtue of careful listening, for example, but this approach remains limited to, well, to interpersonal relationship. And according to Fricker, it is the responsibility of epistemically well-positioned agents, epistemically more powerful agents, if you want, that physicians would definitely fall into this category, to counteract the injustice that a patient is experiencing. But in this case, it seems like physicians themselves are also, to a certain extent at least, disadvantaged by how the regulatory setup guarantees the use of these systems in medical practice. So if I, as a physician, can only prescribe opioids to someone who has a high risk for it, the risk of losing my practicing license, I'm not really free to do what I think is the best course of action. And this hinders them in, supporting basically patients in overcoming their own, the injustice that they experience. So I think for the sake of time, I'm skipping this. Just some ways forward. So, and this is of course not meant to be I don't think there is a winner takes all solution to this kind of concerns. But some ways forward could be, well, first of all, one could say, well, we don't always need patient involvement, right? So, for example, this is the case of an AI system used to scan skin lesions and classify the certain moles as cancerogenic or not, for example. Fair enough. So there are cases in which epistemic justice or injustice might be simply less relevant, because in this case we have patients who undergo a certain test and are passive, information is passively extracted. And this is absolutely fine. So in this case, it seems like we just don't really need something more to the experience of disease that needs to come from patient testimony. So I picked this example, the opioid case, specifically because there seems to be something in terms of knowledge and information about my own perception of pain that needs to come from me. So the idea is we cannot fix this problem only at the technical level by making it less biased, due to the fact that it's a more structural issue. So medical encounters that include an AI system need to make the space for patients to express their own reasons in their own terms, and the knowledge that they hold about themselves that cannot be picked up on by any other agent, probably. So the idea is this, just to clarify. Now, way forward. Well, first, one could say we need to critically question whether a certain AI application in medicine is legitimate in the first place. So one could say, well, this opioid case, it is clear that it's such a deeply entrenched problem, societal issue that is not solvable by an AI system. It's a very quick fix that is doomed to fail. So one could start very upstream and question the legitimacy of a certain application, which I think makes a lot of sense to do, particularly in this case. Also, try to gear efforts toward reducing automation bias and clinicians' epistemic dependence on these systems, due to the fact that they basically make themselves liable if they don't follow through with the treatments with the recommendations of the system. Of course, they are very much dependent upon these systems. So this needs to be taken into consideration at different levels, considering the AI system as a socio-technical system. And this can be done by also training medical professionals about what these systems can achieve and what they can't achieve. So a bit more realistic training of what they effectively can do and can't do, their limitations in particular. And sometimes even a division of cognitive labor can help to avoid over-reliance. And also to make sure that there is always enough space to access what are system-independent reasons for actions, because one might become too dependent on these systems and just overlook other clinically important information that still should play a role. And this is all geared towards the ultimate end of trying to ensure that we do not delegitimize patients' knowledge and the knowledge that they hold about themselves. And also the need to focus on algorithmic recourse. So if I have the feeling a certain risk score has been attributed to me for irrelevant reasons, like in the example I mentioned of this woman with endometriosis, it turned out later that her eye risk score was due to the fact that she had sick pets. And basically the medication that she was buying for the pets were subsumed under her own health record. And this was the reason. But even, I think, once she found out, and this wasn't easy, that this was the reason why she got a high risk score, it was basically impossible for her to clear her record and to show that there was nothing to it. So the issue of algorithmic recourse seems also to be quite important if we want to at least mitigate parts of this forms of injustice. And as I've been mentioning a couple of times during the presentation, all these issues go very much beyond the specificities of a certain AI system considered in isolation. So the institutional, the regulatory setup. These are all things that need to be done at different levels to ensure that we do not have systems that perpetuate these kinds of injustice. Yeah, I think this was it from my side. Thank you.